I practiced in Winter Park general medicine a number of years, and then in the mid-'80s, the powers to be in the medical profession decided that geriatrics has now arrived and should have its own specialty. And so in 1988, the first time the geriatric board exam, and ever since then, was given, and there are now what are called geriatricians. There aren't many of them. You probably don't know any. If I ask for a show of hands, I expect you don't know many geriatricians, but there are a few around. And what has evolved into my main job is training geriatricians, because Florida is woefully behind in young physicians who want to deal with the elderly. Matter of fact, we're sixth from the bottom in terms of the elderly population versus specialists in geriatric medicine. Now, does that mean that all old people need a geriatrician to take care of them? Absolutely not. What it means is we hope that we set the standard, we do the teaching, we do the long-term care, a lot of it work, and see that the standard is as high as it can be for general care of the elderly. Most primary care is rendered by family doctors and internal medicine doctors in the community, and some others too. And that's certainly appropriate, but you want to think or know or feel that your elder doctor has a geriatric mindset. You know, it's funny, that term frail, we kind of all know what it is. It's kind of, you know what your grandmother looks like, but it's hard to describe it. If you look up frail in a medical textbook, it's not there. But we know what frailty is. Frailty is a conglomerate of symptoms and findings in an elderly person, which usually have such things as weakness, slowness of movement, loss of weight, and just general frailty. And often the first sign is a fall. And I can't overemphasize the importance of falls in the elderly. Falls can be life-changing. The outcome of a fractured hip in an 80-year-old female is worse than a heart attack, short-term and long-term. And a fall can lead to a hip fracture, which the person may never be the same. So fall risk is a huge geriatric domain. But frailty is just that general picture, which may or may not represent a specific disease. You know, a cancer could cause someone to appear frail, yet just frailty of itself can also be. In fact, there's a hospice diagnosis, those of you who work with end-of-life care in hospice, called general debility unspecified. That's kind of a fancy word for frailty. In other words, they're really sick and they're really weak, but we don't know exactly what it is. It's just an advanced condition of aging declinism, which I don't like that word, declinism. Declinism implies that because you get old, you're going downhill. What we preach is just the opposite. What we try to do is maintain people in their highest level of functionality as long as possible. We call it compression of morbidity. Have you heard that term? In other words, if you're destined to live 90 years, you want 89.9 of those to be healthy and active and able to play golf. And people do that. Old people are stubborn. Who doesn't think old people are stubborn? And they're independent. They're fiercely independent. And it is really tough sometimes to direct them in the direction that we think they ought to go. So they do make these kinds of errors. But what I implore that you try to accomplish is, number one, that they have a medical home. This is kind of a catchword now in family practice, a medical home, meaning a place, a facility, a doctor, a nurse practitioner, a place that is reachable, that is reasonably accessible by whatever, car, whatever, and that acts as a clearinghouse of medical care for these elderly folks. Now, what we like to tout is a medical home should be a family medicine doctor in the community, and that's fine. It may not be that for your situation, I don't care. What you don't want to see is that the medical home is the emergency room, and a lot of people do that. They go to the emergency room when a crisis occurs. Well, the emergency room doesn't render continuity care. These people need continuity care because their problems are ongoing. They need somebody, an entity with a longitudinal view of the situation. Walk-in clinics are fine for a stubbed toe or a cut nose, but no continuity care. Specialty doctors are excellent in their specialty. And many elderly people have a cardiologist, a pulmonologist, a rheumatologist, a gastroenterologist, and they spend all their time going around, and all of a sudden they have a geriatric domain that we call polypharmacy, which I despise that one, but for good reason. I mean, all these specialists know that in their field, these medications might be appropriate. What they might be not looking at, though, is that there are 4 other specialists prescribing medications. Now there's 25 medications, and the medications themselves become a burden. More of a burden, perhaps, than the condition for which you're treating. So polypharmacy is one that we deal with a lot. So a medical home, someone to act as referee among the specialists, someone to coordinate all this stuff, the medications, the directions, the plan of care, and someone to guide through the maze of the medical circle, which is, you know, what we're going through in Washington right now. One of the reasons all this is going on is the medical system itself has become such a burden. No matter how you look at it, you know, we hope something gets better. And there are various definitions of what is polypharmacy, but mine is any one unnecessary drug. And my plea is, as you deal with your folks, every time there's a possibility of a non-pharmacologic approach to an issue, take it. Don't just throw a drug at it. Just for example, let's say the problem is behavior in dementia. Very common, very big problem. A person has Alzheimer's, and I know you're going to hear more about Alzheimer's later, so I won't dwell on it, but a person has Alzheimer's, but the biggest problem is not the memory, is not the rational thinking. The biggest problem is the acting out and the nights and the noise and behavioral issues. So we have drugs for that. We do, and they work sometimes. But drugs have side effects, and drugs can lead to fall risk, and drugs can lead to worsening of behaviors. And very often there are interventions that don't involve drugs. They might involve family participation. They might involve dogs again. I love my dog. Cats, animals, music, art, odor, believe it or not, aromatherapy. And there's a whole list of non-pharmacologic interventions. I don't want to speak against my profession because I've been there. I've been a practicing doctor. I know what the stresses are. I know the time constraints, the financial constraints, and very honestly, very often the easiest thing to do is write a prescription and end the encounter. And I admit it that I've done it myself. I played a little game one time. I could do it now, but we don't have time. But I could ask you to name a symptom, and I'll give you a medication that fast for the symptom that you just named. But that's not good medicine. Now, what to do about that, doctor? Communication. Talk to him or her and say, this is how I feel about this. Is this really what you want to do? Is this really the best thing? If you don't get good response, there are other doctors. But it's a big problem, I know that. And I don't mean to say that multiple prescribing is wrong. There's good rationale behind almost all of that. It's just that you need a medical home to step back and look at, do you really need 22 medicines just because you have 4 things wrong? See what I mean? All these things we're talking about imply intervention if you find an issue, whether you're screening for a problem or you're dealing with the dementia or whatever it is. But my statement to that is it's not too late just because they're old. They can still backtrack. They can still improve their lot through the things we talked about. Physical involvement, mental involvement, spiritual involvement, engagement with life. You'll never find a healthy, functional, old person who isn't involved. They're not sitting at home watching television, believe me, because we see them all the time. So that's, they can't use the excuse, I'm too old for that. Doesn't work.